Okay, so good afternoon, everyone. Um, I'm not sure if I should expect more people, but in the interest of time, I will start. So since it's a very small, intimate group, I will just start with the question that, are you guys all residents, fellows? Residents? Fellows mix? Okay. And you are like first year, second year? Second year. First year. Okay. Okay, so if you guys don't know me, my name is Dr. Ruhi Khan. I'm one of the physicians in the employee health department of this hospital. So the title of my talk today is Safety First. So mostly you are taught in these type of meetings about how to help your patients. You learn about different diseases to help others. This time I'm going to talk and tell you how to keep yourself safe at the workplace. So our goal in the employee health is to keep all of you safe at workplace and take care of your health while you guys provide your best to the hospital. So today the topic of discussion is occupational exposure to blood and body fluids. As needle-stick injury remains the most common hazard among healthcare workers, especially in our hospital setting. I will focus more on needle-stick injury, hence I will be using both terms, occupational exposure to blood and body fluids and needle-stick injuries. So the awareness of the needle-stick injury started in early 1980s after the identification of HIV infection transmission to healthcare workers after needle prick. And since then, a lot of work has been done to reduce it in workplaces, but it still is an ongoing process. So before I start the actual presentation, I know you guys are very early in your careers, but I would like to ask you a question. Please raise your hand if you ever had a needle stick injury or any type of occupational exposure to blood and body fluids in your life. So 1, 2, 3, 4, 5, 6, 7, 8. 1 out of 8. So I would say that's a big number. So I'm glad that you guys are here, whoever is here, so that you can review what it is all about and I'm talking about it today, and why do we emphasize so much importance on this topic. So this picture shows the occurrence of sharp injuries around the world. As you can see, this is a global problem and it's not confined to one country. CDC estimates 385,000 sharp injuries occurrence in healthcare worker in USA. At one point in time, China had 3.8 million needle stick injury in the healthcare workers. 70% of the nurses experiences needle stick injury in South Korea in one of their studies. And sharp injuries in 1 year at some point in time in the world resulted in 16,000 hepatitis C infections, 66,000 hepatitis B virus infection, and 1,000 HIV infections. So today I will review the basic definitions and the concerns related to the occupational exposure of blood and body fluid, followed by KKH experience, and at the end we will discuss what are the ways to reduce the NSI in our hospital. So first half of the lecture is quite boring, and I'm sorry if you find it very dull. So the definition of occupational exposure is any contact with blood and body fluids or any other potential infectious material that may result while a staff or healthcare worker is at work and performing the job. Example of body fluids is aqueous humor, vitreous humor, exposure with other body fluids like pleural, pericardial, and peritoneal fluids as well, which of course is not common in our setting. Other potentially infectious material include saliva, pus, body tissues, all those things. Now WHO classifies healthcare worker basically anyone working in the healthcare facility, and is not only limited to doctors and nurses. Some of the examples of healthcare workers other than doctors and nurses who are more prone to needle stick injury are lab technicians, CSSD staff, students and trainings, and contractual staff which are not directly employed by KKH, like housekeepers. Now, source patient is the patient whose blood or other infectious material has been the source of exposure to the healthcare workers. This is the big list of the disease can result after a needle stick injury happens. Most of these diseases are not chronic, thank God, and many of them are very tongue twisters, so you can go through the list yourself. I won't go through the list, but in summary, any blood-borne pathogen can be transmitted from occupational exposure to blood and body fluids. The big 3H are not on the list, and those are HIV infection, hepatitis B, and hepatitis C infection, and I will talk about those later in detail. Now, these are the common devices that can be the source of needle stick injuries. Mainly, these are used in OR setting, but you can find one of these in most of the clinical areas in our hospital. 3 distinct times that are associated with needle stick injuries are before and during use, after use and before disposal, and during and after disposal. Now, this data is from Occupational Safety and Health Agency. It shows that with the hollow bore needles, the highest rates of needle stick injury is during use, which is 52%, which makes sense. And some of the examples of this are accessing IV line, during transfer process of a specimen or equipment, collision with sharp or workers, incision and removal of needles and sutures. And this is followed by during or after disposal, which is 22%. The timings for this is usually in transit to disposal, improper disposal, or during disposal. The least injuries happen after use and before disposal, which is 19%. Examples of this are during the activation of safety features, recapping needles, and during cleanup. Now, for injuries that involve solid sharps like scalpels and other sharp instruments, the trend is slightly different. During use is the highest, which is 70%. After use before disposal is 15%, and during or after disposal is only 3%. So what are the factors that affect the occurrence of needle stick injury? Some of them are equipment design, nature of the procedure, condition of work, staff experience, recapping, and disposal process. All of these has been mentioned as factors that influence the occurrence of needle stick injury. For example, if the room is not well lit, the timing of the procedure has a role as well. Usually the rates are found to be less in the early morning time as everyone is well rested and there's less stress, and the rates are higher for the last part of the day as it can affect the performance of the staff due to fatigue and other factors. Transmission of infection is dependent on many factors like mechanism of exposure, how deep the injury is, how big the needle is, and the type of the needle, the amount of the blood on the needle or instrument, health status of the source patient, and amount of infectious organism which is present in the blood that came in contact with the staff. The most common injury that can break the skin and result in exposure to blood and body fluid is percutaneous injury. Examples are needle stick and other sharps, and also bites that can break the skin. Now, the second type of exposure is mucous membrane contact. For example, spray or splash to eyes, mouth, and nose. Skin contact, either contact with the non-intact skin or prolonged contact with the intact skin, can be the source of transmission of infection as well. And the last one, which is rare in our setting, is bite injury, which can result in contact with the blood. As this is the most common one, the percutaneous injury, I will explain this a little bit more. So as I mentioned, percutaneous injury can result from contact with contaminated needles or instrument that can penetrate or abrade the skin, and this poses the greatest risk for occupational exposure to blood and body fluids. Now, the classification for percutaneous injuries. We can further classify these injuries according to the nature of the risk, which determines the need for further testing and post-exposure prophylaxis. No risk percutaneous injuries includes needles or sharps or bites that did not come in direct contact with the patient's blood or body fluid, for example, IV piggyback needle. Low risk includes solid needles injuries or superficial scratches without blood, for example, needle used for intramuscular or subcutaneous injections. Bite injuries that results in exposure to patient blood are also considered as low risk. Moderate risk percutaneous injuries include superficial scratches with minimum blood or other potentially infectious material. And high risk injuries are those caused by intramuscular or subcutaneous needles with visible blood from source patient or the device that has entered the artery or the vein of the source patient. A contaminated large bore needle will be considered as the highest risk of exposure. Now, all mucous membrane exposure, for example, eyes and mouth involving contact with blood or body fluids or other potentially infectious materials, are categorized either as low risk, meaning only few drops of blood for a short duration came in contact with the mucous membrane of healthcare worker, or moderate risk in which the exposure with several drops of blood, major blood splash or spray that lasted for several minutes. For cutaneous exposure of non-intact skin, it will be a low risk if it comes in contact with only few drops of blood and for a short duration of time. And it will be classified as moderate risk if it comes in contact with large amount of blood for a long duration of time. For intact skin, the exposure is usually considered low risk, and it has to be for at least more than 10 minutes of duration. Contact with other body fluids like tears, sweats, urine, feces, unless they are visibly bloody, does not require any investigation, any follow-up, or any treatment for blood-borne pathogen transmission. I'm very sorry for this heavy information that may not be required on the part of your clinical practice, but it is very good to know the basis of needlestick injury. For us in EH, it is mandatory to know all the above information for the proper management of needlestick injury. Now, let's focus on the practical issues. Most common infections that can result from occupational exposure to blood and body fluids are these three: hepatitis B virus, hepatitis C virus, and HIV. These are most worrisome ones because they are chronic, and not only they can result in organ damage or cancer later on, but also the treatment options are limited for these three. Okay, so the HIV, the risk of transmission is 0.3%, which means that 1 in 30 people can get infected after exposure. Risk of transmission of with hepatitis B is 6 to 30%, which means that 1 in 3 to 15 people can get infected after exposure. And some data suggests that hepatitis C is 1.8%, which means 1 in 6 people can get infected after exposure. I will now briefly discuss the important points of EH policy of exposure to body and blood and body fluids in regards to the steps that should be taken after exposure to the needlestick injury. So how to manage needlestick injury after it happens? The first thing is to please don't panic. Please stop whatever you are doing and pay attention to the injury. Don't try to finish the procedure you are performing. Just hand it over to someone as soon as possible and take care of the injury. Clean wound immediately with soap and water, and there's no need to squeeze the wound. With mucous membrane, example is splash in the eyes, you should flush the area thoroughly with water, notify your supervisor, and immediately visit EH or ER if it is after hours. So we established this rule with Infection Prevention and Control Committee that all needlestick injury should be reported to EH within 1 hour of the injury, and thanks to the cooperation of the doctors and the nurses, we are successful in achieving this target. We ask you to bring source patient assessment form with you, as you know that all the management is heavily dependent on the assessment of the source patient, and file incidents report. This is a very crucial step. It helps us learn that what can be done in the future to avoid needlestick injury based on your experience, and it is also very important as we cannot improve our system if we don't know about the incidents. Do you guys know how to report incidents, any incidents in the KK Salama system? Good. So after initial steps, you will be directed to EH by your supervisor, where you will be fill employee assessment form. EH will evaluate the exposure type for further management. We will order labs depending on the nature of the exposure and history of the source patients, and we will request you to proceed to the lab for the necessary blood test. We usually order HIV, hepatitis B, hepatitis C, and the test for syphilis, VDRL. In case of cutaneous or mucosal exposure to non-bloody fluids, we only order hepatitis B and hepatitis C. Now, EH aim is to have the results within 24 hours, so we can determine the need for post-exposure prophylaxis as soon as possible. Regardless of the nature of the injury, we always recommend that all the employees should get their tetanus toxoid vaccination every 10 years. If the wound happens to be dirty, you can repeat the dose. Usually, most of the time, this process is very smooth. Needlestick injury happens, staff and EH follows the protocol. The staff came for a quick visit, a hello, exchange of information, and a goodbye, and that's it. Then EH will contact their staff again after 6 months to repeat the test. But at times, it can be a very nerve-wracking process in case the results are not according to what we are expecting. So now it's a result day. Post-exposure prophylaxis or PEP management for HIV is case by case and is usually dependent on the source status and the exposure type. If the source is known positive or unknown and the exposure is high risk, then PEP is generally required. If post-exposure prophylaxis is required, it should be initiated within 2 hours of the exposure and maximum of 72 hours. The effect of PEP after 72 hours is not well established. The duration of PEP is 28 days and it is recommended to use 3 or more antiretroviral drugs. We refer the patient to ID consultant and further testing of source patient for viral load is ordered. First follow-up is within 72 hours and on as-needed basis. It requires patient ongoing counseling regarding the situation and management. Test for HIV is repeated at 6 weeks, 3 months, 6 months after initiating the post-exposure prophylaxis treatment. In EH, we also repeat it at 1 year as well. This is a busy table. It shows when is PPP required if the source patient is positive for hepatitis B. Basically, if the healthcare worker is fully vaccinated and blood test has shown the immunity to hepatitis B, then there is no need to worry. If the staff receive full series of vaccination twice and does not develop immunity, we call them non-responders, and they will need hepatitis B immunoglobulin twice if the source is positive. If healthcare worker response to vaccine is unknown and the source is positive, we will test them. If they're immune, then no worries. If they're not immune, then we will start hepatitis B immunoglobulin, and we also start revaccination. Unvaccinated employees, incomplete vaccination, and vaccine refusers, we will start with hepatitis B immunoglobulin and offer them vaccination. For hepatitis C virus infection, unfortunately, there is no post-exposure prophylaxis treatment available so far. So if the source patient is hepatitis C negative or status is unknown, then repeat testing for the staff is done at 3 to 6 months. If the source is hepatitis C positive, then the employee is referred to ID consultant. Basically, if the source patient is positive, employee will be treated as having a chronic hepatitis C infection, and testing for hepatitis C RNA is done for the source patient to assess the viral load. So anytime if they see a conversion to any of these viruses, the healthcare worker can be restricted from some work duties that may require close patient interaction based on the viral load of the disease of the healthcare worker. So for syphilis, as per CDC recommendation, we also check the status. If the VDRL test is positive for the source patient, then we check their staff again in 6 to 8 weeks, and the test result is positive, we treat them. Now I will focus more on the KKH experience, and that is why we arranged this presentation, because we are trying to minimize the rate of needle stick injury in our hospital as much as possible, and honestly we are not very successful in that so far. So we conducted a study in KKH in 2023 regarding needle stick injury, and this table is from that study. Sorry for a small image, but basically this study is focusing on the rates of NSI from 2013 to 2021. There were a total of 201 staff who had needle stick injury during that period. The classification of needle stick injury is based on occupation, location, context of injury, mode of prick, prick site, and types of prick. I won't go in details, but I want to stress on the point that every month, an average of 2 healthcare workers came very close to getting chronic infection that can be caused by above mentioned viruses like HIV, Hep B, Hep C, but due to KKH policies and procedure, and I would say their luck, they are safe. So most of the NSI, as you can see, occurred in physicians because of the nature of their job, followed by the nurses. This is KKH data from last year. So total number of injuries were 49. The total number of doctors who had needle stick injury was slightly more than the nurses, but we have subcategorized the rank of doctors for a detailed study. There were 7 consultants, 8 fellows, and 7 residents. So as a resident, if you are getting needle stick injury, don't feel sad, because all around the career, the numbers are almost the same. So in comparison, 20 nurses and 22 doctors had needle stick injury last year, followed by the rest of the hospital areas. So this slide shows the area where needle stick injury happens most frequently in 2023, and of course it's mostly OR, which also makes sense, but I wanted to emphasize that it can happen in any area where needles or instruments are used, as you can see in clinics, floors, CSSD, ERs, and other areas in the hospital like the lab area. So the employee assessment form is the form that is filled after NSI happens. It has a section where the employees had to explain how the injury happened. I copied few statements and I want to focus on it, and I request you to please evaluate the situation in your mind and see if it could be prevented or not. So let's discuss the scenarios. So it says that I was performing surgery on a patient and accidentally pricked myself with the instrument. Now, why did that happen? Was it because of performance fatigue, lack of attention, patient was not cooperative, experience was little less than like the new employees, or I don't know, but it could be prevented? I would say most likely yes. So this says, while removing sutures from a patient's eyes, I accidentally pricked my thumb. Same analysis as before. Why did it happen? And could it be prevented? I would say yes again. I was doing a subconjunctival injection. The needle pricked my finger. Again, could it be prevented? Yes. The surgeon was returning the instrument. While receiving it, I accidentally got pricked. So what happened here? A little bit detailed analysis. So I think here the policy and the procedure was not followed, and the lack of attention on both parties, and there could be other factors as well. So again, sorry, I'm not trying to blame anyone, but I'm trying to make you think that this could have been prevented just by following the policy and the procedure. And as far as I know, the policy and the procedure states that hand-to-hand transfer of the instrument is not the part of the policy. The used instrument have to be placed on the tray and not to be handed to the staff. This one says, my colleague pricked my finger while suturing an autologous dermis graft. I hope I copied it right. So same situation here. It may not be the direct fault of the staff who had NSI. So the lesson is, if we are not extra careful, we can not only hurt ourselves, but we can hurt others as well. This says the nurse was handing surgeon the needle, and she pricked my arm by accident. So this one is more interesting. When I read this one, the thought came to my mind that who is this third person, and what is he doing with the procedure was happening? Is he an observer, or she or he an observer, a helper? Was that person really needed in that situation? I don't know the details, but God forbid, if the patient had acquired any infection after this, there will be two more people who might be carrying the guilt of the whole incident the rest of their life. This one says, after extracting the blood from a patient, I accidentally splashed the blood on my eyes. This was one of the very few examples of mucosal exposure injury that I could find. The rest of the injuries and majority of the injuries that happen in our hospital are needle stick injuries. So now I will tell you a small story. I really believe that storytelling is a strong means of communication, and the message is usually delivered more effectively. So we had two staff in our hospital that were exposed to HIV patient. For the sake of confidentiality, I have tried to change the gender and the situation a little bit. So Mr. X was working in OR and had a needle stick injury. As the patient was very incooperative and he was pricked by his colleague, it was not his fault. It was a routine scenario. He came to EH, blood was drawn, EH got the result, and the source patient was positive for HIV. Now this patient did not inform the doctor about his status during his visit to pre-hospital to get the surgical clearance before the procedure. It was a shock for the employee and for us as well. Now the next step was to start the PEP according to the policy within 2 hours to be most effective, and the maximum 72 hours. So we tried to get the medications through KKH pharmacy, private pharmacy, personal contacts, whatnot. You can imagine all the concerned department, they were working very hard to get the PEP. Now, MOH has a policy that HIV medications are only available by request, which is very time-consuming process. And eventually, just before the completion of 72 hours, we were successful, and our employee got the post-exposure prophylaxis. Now, imagine the psychological trauma of the news that the source patient is positive, that was caused to our staff, the initiation of hardcore medications for a month, the burden of side effects, the stigma at work and in personal life. It was a very difficult situation and process for the entire involved departments. So as a committee, we arranged HIV and hepatitis B prophylaxis to be present in KKH all the times after this incident, although they are very expensive and the short expiry date. But the committee decided it's worth it, and just after 2 months, the second exposure happened. The source was known HIV and hepatitis B positive this time, and Mr. Y got the needle stick injury while he was doing some procedure with the patient. This time we were very happy, we patted our back, we were ready, and the medications were started on time. But once again, we could not prevent the psychological trauma for Mr. Y, who had to postpone his upcoming wedding for 1 year, and he had a full-blown anxiety, to the point that every time he had to go for the blood test, we really have to convince him to go because he had such a big fear of the result. Not only that, he also avoided his colleagues and he became very isolated. Anyways, thank God both of our employees are very well and doing very healthy and doing well in the hospital. So the next slide is to show you what can happen after needle stick injury with a positive source happened. Of course, it can result in the risk of acquiring infectious disease like HIV, hepatitis B, hepatitis C, the most common one. It can cause big-time psychological trauma, months of anxiety, fear of outcome, the burden of prophylaxis medication, its use and its side effects. It can also result in job discrimination and lack of empathy from the colleagues. And of course, not only it affects your work life, it does affect your personal life as well. We have witnessed all of these in both of our employees who had the needle stick injury. This is a paper that I found very interesting. It also confirms that psychiatric illness can result from needle stick injuries with a severity similar to other psychiatric trauma. Swift delivery of test results may reduce the duration of depression associated with NSI, but even after that, the effects may remain for a few months. Now, time to discuss how to avoid needle stick injury, what we already know and how can we further improve it. So these are the few things that are mentioned by the experts. The number one is please always follow the recommended guidelines. And if you see someone not following the guidelines, don't be shy, don't be embarrassed. Just tell the person, please do the right thing, because it will never be held against you if you are following the guidelines. Improving equipment design, elimination of unnecessary exposure, engineering control, work practice control, effective disposal system, employees training, personal protective equipment use, safe recapping procedures where necessary, and surveillance programs. So we are doing all of these things. Still, we are not very successful in reducing the rate. So this is the alert sign. You will find it in many places around the hospital. Have you seen this before? Good. So it talks all about the important things. It talks about how to prepare injection in designated areas, ensure the adequate lighting, use of the aseptic techniques, do not share needles, do not use needles, do not reuse the needle or the syringe, do not break or bend the needles, keep your hands away from the point of injection, do not recap the needles, dispose sharps properly in the sharp bins, using a tray in passing the devices, and minimizing distraction. These two are very important, that because most of the NSI, when we do the root cause analysis, these two factors are on the top. Never hand the dirty instrument to someone, always put it in the tray, and always do your best to minimize the distraction. So do you know about the hepatitis B vaccine policy in KKESH? So at the time of pre-employment, I'm sure you guys have been through that. EH makes sure that the employees has immunity to hepatitis B. Otherwise, we do vaccinate our employees. If you are not sure about your immunity status, come to EH and we will test it for you. MOH recommends yearly test of hepatitis B antibody for employees who are at high risk of needle stick injury, like surgeon and anesthetists, but it is not mandatory in KKESH yet. One of the ways to reduce needle stick injury is to eliminate or reduce needle use during procedures, medication delivery, and specimen collection. Engineering control is important. Remove or isolate the hazard by using sharp disposal containers. Use the devices that have an integrated injury prevention features. Safety devices must be chosen with care, as no one single device strategy will work in all the situations. For work practice controls, steps that can be taken to reduce injuries includes using instrument to grab the needles or load or unroll their scalpels, avoiding hand-to-hand passages of sharps, separating sharps from other waste, not carrying garbage or linen bags close to the body. Few other important things to review. Please cover open skin area lesion with dry dressing while you're at work. Hand hygiene is very important. Protect your eyes, nose, and mouth if it splashes with blood or body fluid is anticipated. So we have a surveillance program for needle stick injury in KKESH, which involves collection of the data, monthly presentation of the data according to which steps are taken by the committee to reduce NSI, and this, excuse me. So, as I was saying, that this presentation is a step forward to meet the goals to reduce NSI. So, personal protective equipment is very important. Very important to use gloves before the procedures, face shield if there is a chance of a splash injury. Basically, always use PPE where it has to be used. So the take-home message, last but not the least, be mentally prepared to avoid needle stick injury while performing or assisting a procedure. Be mindful of your own situation and your surrounding, and don't hurry, take your time. And always remind yourself before starting your day that today I'm going to prevent needle stick injury for myself and others. It might help. Stay calm and focus on improving your own style to prevent injuries, and please follow the protocol. So I finished a little early because I'm hoping to have a very active discussion and suggestion from you all about what steps should be taken to reduce needle stick injury in our system, since you guys know the ground realities while you're at work.